Dr. Zakulik, this is your 6th month meeting.
Yeah.
So you have had access to your evaluations and your assessments, I'm sure.
Yeah.
So let me just preface by saying I know these past few months, and particularly probably these last 2 weeks, have been difficult for you, and indeed I would say different than the rest of your residency. Would you agree with that?
Yeah. It's been brutal.
Yeah.
It's been bad.
So I've received a lot of feedback from the attendings you've rotated with, and in fact I've received phone calls, emails, of course the evaluations that you've already had access to. And so my first question for you is just sort of how are you doing with all of that?
Honest, it's like I said before, it's brutal. I didn't sleep at all last night.
Yeah, I can imagine.
And yeah, when you find out there's been all this discussion about you behind your back, yeah, it's been hard.
Yeah, I can imagine it has been. So what I want to know is, did anything particularly surprise you that you read or that you were told?
There's so much. So, and some of the stuff that like is an assessment was just so petty. Like, let me tell you, this one portion in my assessment was she didn't use the right progress note template. I was rotating for 3 months. No one looked over and said, hey, we use this template. No, it comes in my assessment. So the first time I find out about the template is yesterday. And apparently, I'm the bad communicator.
Anything else that you noticed in particular that surprised you?
I try and come up with a good diagnosis, be firm with it, and defend my diagnosis. And honest, I guess it just all came off as
arrogance.
Yeah, I guess arrogant. And I read one of those emails, and it said that I called the nurses liars.
Yes, tell me about that.
Well, first up, not true. Did not call the nurses liars.
Okay, but you were directly quoted.
So unfair. To quote me, and I don't even have an opportunity to defend myself. I'm sure it didn't go down that way. It's just, it was just the way they were representing things, and I'm sure I didn't use those direct words.
Well, so then, but why do you think that happened?
Like I said, I didn't sleep at all last night, so I spent a lot of time thinking why this happened. And I think maybe at the beginning of when I got there at the VA, there were some times where there was miscommunication, and then all of a sudden I was labeled the bad resident. And like, once you're the bad resident, it's easy to find things, and it was just like a pile on.
Okay, so tell me, when was the first time that you received feedback about your performance on this rotation?
Well, I thought there were some, like, the last couple of weeks. I know that I've been getting this feeling that there was negative.
But when did you actually get feedback specifics?
Yesterday at 3 p.m. And let me tell you how that went down. Because, like I said, I thought I was getting this feedback before, and or I was sensing that people didn't feel comfortable with me, they didn't trust me. And I tried to pin down my attending, and I said, listen, I'd like to sit down and get some feedback. And he told me, oh yeah, tomorrow, we'll do that tomorrow in the morning. And I went in the morning, and he didn't have time. And then 12 o'clock came, and finally at 3 o'clock, I was like, listen, please, we need to chat. And at that time, he, gave me some comments that I should know that in general, the attendings did not feel safe with the care I gave their patients. And then after that, I received this sort of general email from one of the preceptors that said, so here are your negatives and here are your positives.
Okay. And some of the positives were?
Oh, my penmanship. I have good penmanship, apparently. On the wrong template, but good penmanship.
Oh, dear.
And then, and then it said something like I was professional. And then all the negatives make me look like I'm totally unprofessional.
Right.
So I don't know what I'm supposed to do with that.
Right, right. So can you give me any specific examples? Clinically, did they give you any reason for why they don't think you are safe with patients?
So let me tell you, because this was in the assessment, this episode, but let me tell you from my point of view.
Okay.
So there was this time early on, I was trying I was working overnight. There was a patient who was short of breath. And I'm like, oh, is it COPD? Is it congestive heart failure? And I was sort of tired. And I went to present to my attending, and he started grilling me on my diagnosis. And I kept trying, and I couldn't, I just couldn't get to what he had in mind.
Mm-hmm.
And then finally what he does is and on a piece of paper he writes pulmonary embolism in big block letters and moves it over to me like I'm an idiot.
Right.
He couldn't talk me through it.
Right. Okay. So, well, first of all, let me say I'm sorry for that. That's not really a great way to provide really any kind of instruction to a resident. It probably wasn't really the best choice on the part of that attending. But what I'd like to do here now for a minute is just sort of take a step back, and I want to ask you a question. Let's just assume that although the feedback that has been provided for you perhaps wasn't as constructive as it could have been, and on our end we might have been able to do a better job, but I want you to think a little bit about your performance, and if you can come up with something that you potentially did or could have done that would have changed the outcome of how this rotation went.
Well, going back to that portion where I said that they perceived me as arrogant, for sure everybody can do better. It's not like I'm saying that I can't do better.
Right. So what would you think would have been something you did that might have made this worse?
Well, I think that sometimes because I'm very sort of loud
Mm-hmm.
and assertive, that the attendings think that I'm challenging them.
Right.
When I'm really just want to talk through my diagnosis, and I want them to challenge me back.
Right. But to be fair, we've worked together on more than one occasion, and I have felt that sometimes our interaction is almost combative.
But I don't mean it that way.
Okay.
I don't mean it. And, I'd like to not do it that way, but if I start with, I don't mean to challenge you, then it sort of sounds like
you're going to challenge me. Right. So maybe we could come up with a way that you could preface it, though, that would be a little more subtle, a little gentler, that would make the interaction go more smoothly.
Well, thinking back to the other episode, maybe if when I was struggling with the diagnosis, if I had suggested, please, tell me more of what you think is going on.
There we go. Maybe that would have come across a little bit better. Tell me more about that. Oh, I didn't think of that. Maybe you could help me out. Maybe you could tell me more. Not leaning forward and just saying, well, where did you come up with that? I don't see any evidence for that here.
Yeah, no, I guess that doesn't
because
come
I think
off, right?
that, kind of sends the wrong message. So I think, and this is something that I have felt in my training as well. If you're sort of a loud personality, and if you put yourself out there, and if you really do want to take ownership of the patient and make a stab at the diagnosis, those are all very, very good things. But sometimes it can come across as being overconfident, too assertive, even potentially arrogant. So one of the things that I think would be a good idea is if you just gave your preceptor sort of the insight into that from the very beginning. So you would say something like, look, I know I come across as being a little bit loud, and maybe you might think I'm overconfident, but I'm really not. I'm not obnoxious. I really need your feedback, and I need to depend on you as my teacher, that you will tell me what I'm doing well and what I'm not. And I really count on you for that. So I hope that's the relationship we can have. And if you kind of set the groundwork for something like that from the beginning, then maybe you'll find you can have better interactions.
Yeah, yeah. Like sort of the concept of like introducing my personality.
There you go. That's a great way of putting it.
Like,
yeah.
I'm a little loud, but I really want to discuss these cases and I want to learn.
Right.
And I want to learn from you. You know, it makes me think this. When I was a medical student, I was on my surgery rotation, and after the first day, that my surgery preceptor took me aside and said, you know, you might be helpful to tone it down a little bit. We're not quite used to your level of enthusiasm in the OR. And it was painful to hear. I mean, I got what he meant, and the rest of the rotation, rather than just say the first thing that came out, saying it, like I took a deep breath, and it was more thoughtful, and it ended up going really well. And in the end, that preceptor, to this day, I think of him as a mentor, and I'll go and I'll ask him, for advice.
Good. Good. I think sometimes you have to give your teachers permission to be great teachers. And if you can do that, if you can have that kind of exchange with them, then maybe things will go better.
Yeah.
All right, so that's something I think that you're going to work on for the next rotation. Now, before we end, I do want to just sort of float one more thing out there, and that is that the story that you told about the pulmonary embolism actually belies another issue here, right? So apart from the communication and interpersonal skills, there seems to be some question about your patient care and your medical knowledge with regards to differential diagnosis and perhaps even early closure. So the other thing that I think what we want to do is talk about here a little bit is how we can make a plan for that, a plan for improvement with regards to differential and patient care, because that will also help tremendously in your future rotations.
Okay. All right. Thanks. All right. Okay. So turns out,